One, go.
Hi friends, I am Dr. Pramod Jog from Pune, and today we will be discussing a topic on allergic rhinitis and allergic disorders. And two of my dear friends, Dr. Anuj Rastogi from Meerut and Dr. Divyang Pathak from Varanasi, will be with me to discuss this topic threadbare. And I assure you that at the end of the program, you will have a lot of information about the allergic rhinitis and allergic disorders in children. Now, to tell you frankly, every day in the morning, I get up with the alarm set up by the sneezing of my wife. Okay. And for the last 30 years, she wakes me up simply by her sneezing because she has allergic rhinitis. And I will tell you the way to differentiate asthma and allergic rhinitis is this way. If a person gets up because of cough early in the morning, that is asthma. And after getting up, if he sneezes 50 times, 100 times, that is allergic rhinitis. And this is how you should remember what is allergic rhinitis. Of course, we'll go into the details of that. And to discuss all these problems, I will just introduce Dr. Anuj Rastogi, who is a senior pediatrician from Meerut. He graduated and post-graduated from Meerut, and he is heading the Department of Neonatology and Pediatrics at the Jaswant Hospital, which is a 150-bedded hospital with NICU and PICU. He has also his own setup for the last 12 years. That is Tara Kids Hospital, Tara Kids Center. And by this name, he has a Facebook page also. He has quite a few YouTube videos. He's also active in health education of the parents by writing write-ups in the newspapers and magazines. And he's a very close friend of mine. Dr. Divyang Pathak is from Varanasi. He graduated and post-graduated from Pravara Medical College in Maharashtra. And then he has experience from the Medanta Hospital and Sir Gangaram Hospital in the intensive care. He has a special interest in intensive care and pulmonology and bronchoscopy. And today we will discuss the topic of allergic rhinitis and allergic disorders in children. The most important thing is as to why we should discuss this problem is, one is, of course, we should have a clear understanding of what is allergic rhinitis. Secondly, quite a few children who come to our clinics with bronchial asthma, many times they do not get controlled with the inhalers. This is simply because their allergic rhinitis is not properly treated. Remember that 80% of children with asthma have allergic rhinitis as a comorbid. Comorbid means it's a condition which is associated with bronchial asthma. On the same lines, children who have allergic rhinitis may almost 30% land up with bronchial asthma. So it is essential that we know about these problems. And one important thing is the molecule belastin. It's a new kid on the block, and it is quite famous now in the market because it is a non-sedating antihistaminic from the second generation. It's a very safe antihistamine, and we will know a lot about it during our discussion. I will give you brief information about allergic rhinitis and associated conditions in the initial few minutes, and then Divyank will discuss about the molecule, and Dr. Anuj will discuss his experience about the use of antihistamines in the practice, and then we will have a question answer session. So remember, we will first see some cases. Here I would like you to focus on associations of allergic rhinitis. It is not difficult to diagnose allergic rhinitis. Any child who is having sneezing and watery rhinorrhea and congestion of the nose, all these, you can easily diagnose as having allergic rhinitis. However, the associations are important. So let us see this case. She is a girl who is 11-year-old and has recurrent cold for the last 6 months, and she is sneezing paroxysmally. What is paroxysmally? It means she will sneeze in the morning. Afterwards, she will be fine as if nothing has happened. And again in the evening, she will sneeze. So sneezing is more than 50 times in a few minutes. And these symptoms worsen in August and September. This is called as seasonal allergic rhinitis, SAR. Okay, seasonal allergic rhinitis. Many times children come to us with viral infections also. okay, like the influenza virus or the rhinovirus, and it is necessary that we differentiate the two. What you should remember is that in our practice, many times, people also have now started asking us, sir, ye kahin viral to nahi hai na? So, they are diagnosing on their own. So these infections are usually overdiagnosed, but allergic rhinitis remains underdiagnosed. Now, let us see another case. Is a 4-year-old girl comes for cough and cold off and on, but almost persistent for last 3 weeks. But along with that, this particular girl has fever and headache for the last 4 days, and the cough is more in the lying down position. So obviously, our friends now know that this is not plain simple allergic rhinitis where we have only watery rhinorrhea, but there is fever and headache. It means that the sinuses are involved. So we will think whether it is sinusitis, whether it is infectious problem which is leading to inflammation and the infection in the sinuses. Another child is a boy, 5-year-old, with cold and cough going on for 3 months. In addition, he has history of fever and the pain in the earache 2 months back, which subsided with a course of antibiotics. But the cold and the cough do not go away. It's always there, and there is no breathlessness. So we want to know whether this involvement of the ear in this child could be allergic. And another boy, 3-year-old, with cough, cold, sneezing for the last 15 days, severe cough, and it is recurrent for the last 4 months. The general practitioner has given him a course of antibiotics, nebulization, which these days is given as a welcome drink to any child who simply opens the mouth and starts coughing. And he has received cough syrup for 5 days, but there is no adequate response. There is no fever, but cough and the cold persists. So obviously, when a child continues to have these problems for 4 months with severe cough, and one may always think of asthma. And now someone has started on an inhaler for the last 5 days, and the patient has come to you for a second opinion. So what is your impression? So looking at all these cases, remember that the patients come to us with common symptoms. The symptoms are common: recurrent cough, recurrent cold, with few additional points which are different in each patient. And these confusing symptoms should be dissected out and analyzed. Okay, that's why careful history and examination is extremely important. And you have to differentiate whether it is allergic rhinitis or whether it is infectious rhinitis media, because you know that in adenoid hyperplasia we usually have open mouth breathing. Okay, in otitis media you have pain in the ear. Whether it is infection with underlying allergy, okay, we also would like to find out whether allergic rhinitis is alone or whether it is a comorbid with asthma, and accordingly the treatment plan will change. Okay, now the symptoms which are suggestive of allergic rhinitis are like these. I told you that watery rhinorrhea, sneezing, nasal itching, and nasal obstruction are the 4 cardinal symptoms in a child who has allergic rhinitis. And if 2 or more of these are present for more than an hour, 1 hour on most of the days, then these are the symptoms which are suggestive of allergic rhinitis. Okay, but there are symptoms which are not associated with allergic rhinitis. For example, unilateral symptoms. The discharge is only from one nostril. Okay, it could be foreign body or something else. There is only nasal obstruction, but no rhinorrhea, no sneezing, no itching. Okay, that's also unlikely to be allergic rhinitis. If there is mucopurulent rhinorrhea, posterior rhinorrhea, postnasal drip with thick mucus, and there is no anterior rhinorrhea, okay, it means it goes more in favor of sinusitis. Okay, and if there is pain, recurrent epistaxis, anosmia, loss of smell, all these patients, they need to be referred to an ENT surgeon. And as I was going to tell you the difference between common cold and allergic rhinitis, it is important. See, the child who has a common cold, an infectious cold because of rhinovirus or maybe a flu virus, these children, they will have cold, but it will last for only 1 week, not usually beyond that. A child who has allergic rhinitis, the cold will last for more than 10 days. Fever, as you can very well understand, will be present if it's a viral infection, and it won't be present in allergic rhinitis. In, of course, these common cold patients, there will be constitutional symptoms like headache, body ache. These will not be present in allergic rhinitis. On the other hand, there will be some allergic signs like allergic salute and allergic shiners, which I will tell you in a minute. And then in common cold, the nasal mucosa will be red. In allergic rhinitis, the nasal mucosa will be pale. And the children who have infectious common cold, they may not respond to antihistaminics, while those who have allergic rhinitis, they will show a very good response to antihistaminics. The family members in a child who has common cold because of infection, they will be affected. So Dr. Jog will be unwell, his wife will be affected, his parents will be affected. So that's more than a member in the family, that is usually viral. And in allergic rhinitis, only the one who has that tendency will probably be affected. Okay. So you have to now understand that there are some symptomatic clues for allergic rhinitis which are beyond nose. For example, children might have ocular allergy in addition to allergic rhinitis, like watering of the eye, itching of the eye, redness of the eye. This is allergic conjunctivitis. Okay. And the molecule belastin, which we are going to discuss, has an action on allergic rhinitis as well as allergic conjunctivitis. Eczema, these children could have atopic dermatitis. Okay. These children might have fullness in the ear, and these children may have palatal pruritus, itching of the palate. So they will produce, some sounds like, continuously there will be some sensation of itching in the palate. Okay. So these are all allergic symptoms. And the symptoms of comorbidities and complications, which I already told you, like for example, a child who has allergic rhinitis with sinusitis obviously will have headache, bad breath, and he will cough in the lying down position. Remember, children who have sinusitis, they will smell bad for others. They themselves may not get any smell, so they have anosmia, but for others they will smell like a hell. Okay. And then children who have additional adenoids, they will have snoring, that is called OSA, obstructive sleep apnea. So there will be mouth breathing and the voice will be nasal voice. Okay. And those who have ear involvement, they will have some effusion in the middle ear. And those who have asthma will have uncontrolled asthma. So now, my dear friends, you have understood that understanding allergic rhinitis alone is of limited use. You must understand the other associated problems which are in the upper respiratory tract. Okay. So all the four cardinal symptoms which I told you are because of chronic inflammation. Chronic inflammation of what? Of the nose. And why does it occur? This is because of the IgE antibodies. And where do these IgE antibodies come? These are because of the allergens. That is why it's an allergen exposure which leads to the production of IgE antibodies. What these antibodies do is that they sit on the cells called as mast cells, and these mast cells, they release histamine, and release of histamine is at the back of most of the symptoms of allergic rhinitis. This is very important. That is why antihistaminics are the major players in the treatment of allergic rhinitis, which affects almost 5 to 25% of children. Okay. And if you look at the natural history of allergic disease in children, you will find that the red line tells you that in the beginning, in the first part of life, in the first year of life, you have GI symptoms like cow's milk protein allergy and others. Later on, little later, they have eczema, the green line, but both these problems, they subside later. In little older children, preschoolers, they start that yellow line showing, preschool wheezing, which may go up onto asthma, and the violet line, the allergic rhinitis, which starts little later, okay, and may persist all throughout the life. So this is the relative prevalence of symptoms according to the age. Now, allergic rhinitis, whenever a patient comes, you must ask for all those symptoms like running nose, which has a clear watery discharge, along with sneezing, itching, and a nasal block, along with the involvement of the eye for itching and redness, and also atopic eczema, asthma-like symptoms, and family history of allergy. These are important points. And when you ask these symptoms, otherwise what happens in our busy OPD, we will ask the patients, yes, what is the problem? He says, sir, there is runny nose. We hardly ever examine for sinuses. We hardly ever use the otoscope for examination of the middle ear. We hardly ask whether there is mouth breathing. We hardly, think of asthma. So all these things you must think, because that will, of course, impress the patients, and you will also get a satisfaction of dealing with common cold. Otherwise, what is there in treating common cold? Anybody can give antihistaminics and send the patients away. But other comorbids, if they are not treated, that will, continue for a longer time. And when you examine, you have certain signs like, this child has itching of the nose. The nose needs to be satisfied in every person, right from birth to death. Okay. So everyone has his own ways of satisfying the nose. And this is called as a nasal dance. And these are nasal mannerisms. There are some allergic shiners, who have little bit of darkness under the eye. This is because of venous congestion. There is a transverse crease at the junction of the cartilage of the nasal bone and the cartilage, and that's the one which is seen in the nose in this child. And some children have allergic salute, so you can see this child in that particular posture. Now these symptoms are grouped into two. There are some who are sneezers and runners, so they have sneezing and watery rhinorrhea with itching, and these are the ones who are worse during the daytime, and they are better at night. But there are others who are blockers. Naak band padta hai, so those are the ones who don't have much of sneezing, but they have a thick mucus, very bad congestion, and they are worse at night. And we will see as to which medications work for the first group and which ones act for the second group. And on the basis of all these, there is a group called ARIA, that is allergic rhinitis and its impact on asthma. And the group gave a classification dividing all these children into some 4 categories. So some of these kids might come to you intermittently, meaning thereby less than 4 days in a week or less than 4 weeks in a year, or they may come to you persistently for more than 4 days in a week or more than 4 weeks in a year. And these chaps could be either having mild problem or moderate to severe problem. What's a mild problem? Where the sleep is not disturbed and the child have no affection of his activities. He continues to go to school without any problem. While those where the sleep is disturbed and the activities are affected, they are the ones who have either moderate or severe problem. So classification goes as, either he is mild intermittent, or he has moderate to severe intermittent, or mild persistent, or moderate persistent. So it's anybody's guess as to what is the group, but you should know as to how you classify them. These are only guidelines. Some variation here and there is bound to be there, but you should know what is the difference in the management of all these. And before that, you must know that the environmental control is number 1 in the management of allergic rhinitis. Okay, so these triggers could be outdoor, outside the house, like the pollens. I know of children who start sneezing when they climb the first staircase of the first floor, and in the balcony there are some flowers yellow in color, particularly in winter, and they release the pollens and children start sneezing. So pollens, the most common for the outdoor allergy, they come from tree, grass, or the weeds. And there are majority who are having problem allergens from the inside of the house, indoor allergens like the house dust mite which is there on the bed and the linen, the fungal molds which are there on the walls, the pets like the dogs and the cats, and the cockroaches in the kitchen. So all these are the indoor triggers. And there are others who are called as irritants. Okay, so that's the cigarette smoke, a father who is a chain smoker, or a mosquito coil which is burned in the evening, and cooking fuel and air pollution. So we have to avoid the environmental triggers, and it's extremely important, and that is the mainstay of management of allergic rhinitis. Now in addition to this, you have to use drugs also, and the drugs are like antihistaminics and the leukotriene receptor antagonists. Today we are not going to discuss about the leukotriene receptor antagonists, though we will make a mention when it is necessary. But you should know that the approach of allergic rhinitis management is a stepwise approach, and particularly for children who have mild intermittent involvement. That means they come to you intermittently. Okay, for them, of course, allergen avoidance along with second generation non-sedating H1 antihistamines are definitely necessary. But those who have moderate to severe involvement or a persistent problem, for them intranasal steroids are very, very important. Remember, intranasal steroids are better than the leukotriene receptor antagonist. This you must understand. However, in all the categories, the one which is definitely used is the antihistamine, and that is why we are going to focus more on antihistamines, particularly on bilastine, in a short little while. Now, as I told you that the allergic rhinitis is associated with some other conditions like sinusitis. I will just tell you certain important things about allergic rhinitis and its comorbids. So one of them is, of course, asthma, and you must know that 30% of children who have allergic rhinitis, they have asthma, and 80% of asthmatics have allergic rhinitis. This has to be clear. And as I told you, allergic rhinitis is a risk factor for asthma because they share common allergens. Okay, all the allergens that I told you, they are shared in common by these two conditions, and that's why it's called a unified airway disease. The airway from the nose up to the lungs is the same, and that is the reason you have to remember this name, unified airway disease, or a concept. Okay, and proper treatment of allergic rhinitis will improve the asthma control. And allergic sinusitis also you must know, because it is rhinosinusitis. Rhinitis with sinusitis, they exist together, and the correct term has to be rhinosinusitis, where the symptoms are nasal blockage, nasal discharge. As it is a combination, it will be anterior discharge as well as posterior discharge. I told you there will be halitosis, that is bad breath, along with loss of smell. The child will have facial pain, headache, and he might have pain in the ear. The x-rays are not very specific, and CT scans are unnecessarily taken, though they give greater details. They do not guide about the etiology, and the treatment of sinusitis is same as that of allergic rhinitis. However, if there is bacterial infection, you need to treat with antibiotics for 10 to 14 days. Okay, and certain children who have a severe deviation of the nasal septum, or a glued ear, or a child with allergic rhinitis with refractory sinusitis and adenoid enlargement, or obstructive sleep apnea, nasal polyps, these all need to be referred to the ENT surgeon. Now, remember that if you want to know the most important things about allergic rhinitis, you have to look for the 4 cardinal symptoms, watch for the comorbids, rule out infections, also control the allergens, and use the antihistaminics or the intranasal steroids or the leukotriene receptor antagonists depending on severity. And remember that the treatment of allergic rhinitis improves the asthma control. We are not going to discuss about immunotherapy, which is required in rare cases. And a few words about urticaria, because the molecule belastin has a very good role in the management of urticaria. Remember, urticaria is characterized by transients. Okay, transients. So there is someone who has some food allergy, for example, milk or nuts or soya or eggs or some of these things, and the child starts having itching on the body, or a child who has allergy to certain fish. So all these are the ones which are related to urticaria. In case if urticaria is less than 6 weeks, it's called acute urticaria. Beyond 6 weeks, it's usually labeled as chronic urticaria. And 50% of urticarias are idiopathic. Nobody knows what is the cause, but the basis is histamine. Remember, histamine is at the base, whether it is idiopathic or whether you know that there are some factors responsible for urticaria. There are physical factors like cold. Some people, when they take a bath, they start having itching. Some people who go to the rains, they start getting, these are aquagenic urticarias. Okay, while there are some, as I told you, which are related to the food, and there are some who have involvement of the dermis, that is the layer of the skin below the epidermis, and these children, they get angioedema, the wheals, giant urticaria, and swelling of the lips, and choking of the breath, and cough. These are the ones who are serious. And here, plain simple antihistaminics won't work. Here you have to use adrenaline. Okay, I got a firing from my senior teacher only once when I was a resident, when there was a child who had severe rash on the body, and the child was almost gasping. I had given him only antihistamines and steroids, but he said no, steroids are not the ones to be given here. Adrenaline is the drug of choice. So please remember, my dear friends, you must have adrenaline whenever you go out for a tour, and then you must be ready with that. If you are going to go on to the seashore or to a garden, or going to eat some new variety of fish in Thailand, then please be careful. And if in US, you will get EpiPen, which is nothing but epinephrine, which is injectable in the form of a pen, but costs hell, $600. But then if you want to save your life, you will have to have that. So remember, urticarias also we will discuss in little further details, and particularly the management, in a little while. So my dear friends, I will now request Dr. Divyank to enlighten you about this molecule belastin, after a brief information about the antihistamines, the pluses and the minuses of the first generation antihistamines, the importance of the second generation antihistamines, and some important aspects, positive points about belastin. So thank you for a patient listening, and over to you, dear Divyank.
Yeah, thank you, sir. It was a very great presentation of yours. Hello.
Yes, please continue.
Yeah. So I'll share my screen. Yeah. So till now we have heard allergies and specifically allergic rhinitis and urticaria. But as sir have already focused on that, the antihistamines are the main aspects or the main factor by which the symptomatology appears. So the concept of antihistamines came, and it came 70 years ago. Now, like in 1937, 1942, in between 1950s, chlorpheniramine was discovered, and that have problems with cholinergic activity or sedative activity. Then we move forward to second generation like cetirizine, loratadine, fexofenadine, and likewise we have reached to belastin, that is recently added in second generation at 2010. So we are still discovering these antihistamines, and we'll go forward with differentiation with between first generation and second generation. So what are the differences selectively? Like in first generation, it is non-selective. Like histamines have four type of receptors: H1, 2, 3, 4, and H1 is the main receptor which is responsible for the first generation was not selective on one receptor, so it had anticholinergic effect, and it has to be usually administered 3 to 4 times because of short half life, and it also crosses the blood brain barrier and potentially caused a side effect like sedation and hyperactivity, insomnia. The main other problem was it causes is called QT interval. So it was very dangerous in the people who had QT prolongations or in congenital QT prolonged patients. And there were more and more drug to drug reactions, and they were like CPM and diphenhydramine. Though many of us still use this, but I recommend to do not use these drugs. These have a lot of side effects. Now moving on the second generation, it is selective to the H1 receptor. But in second generation also, as we move forward to the more and more advanced drugs, they are becoming more and more selective to H1 receptor. In previous generations, in previous early generations of second generation, they were not 100% selective to H1 receptors, so had mixed type of profile. These second generation can be administered sorry, once or twice daily because of long half life, and does not cause any blood vein barrier, and so there is no sedation, and it do not cause QT prolongation. Now QT prolongation is better. There is no side effect of QT prolongation on belastin, but earlier drugs like cetirizine and levocetirizine have a risk of QT prolongation, so that can be a contraindication if the patient is a known case of QT prolongation. There is no drug to drug interactions. The second drug examples are cetirizine, levocetirizine, fexofenadine, very famous drug, and belastin, the upcoming new drug. Now, the second generation antihistamines have benefits of binding affinity for H1 receptor. It has faster action and longer duration of action, and reduces the ocular symptoms like rhinoconjunctivitis. Most of the anti-allergics doesn't act on eyes, but in second generation antihistamines can also reduce the ocular symptoms. That is a plus advantage, and it has a lesser sedation. These are the major positive these effects. Now we should know that if we are talking about an antihistamine, then what qualities should an ideal antihistamine should require? So we can divide it into pharmacological efficacy and side effects. In In pharmacological, it should be 100% active, selective to H1 receptor, n- no clinically relevant pharmacokinetic reactions to any other food or medications, no interaction with cytochrome P450, that is no liver involvement, no interaction with other diseases. Efficacy, the efficacy should be effective in both intermittent and persistent allergic rhinitis, and it should be effective in all nasal symptoms, including obstruction, and should improve ocular symptoms also, and should also be given to from infants to elderly patients. Now, in side effects, there should be no sedation, as discussed, no anticholinergic effect, no weight gain. Uh, Cardio, it should be very safe to cardiac patients. It should can be used in pregnancy and can be conducted in young children and elderly patients. So, Bilastin, coming to Bilastin, now, belastin is a new generation antihistamine, which is a modern, non-sedative, second generation H1 antihistamine, which has the highest number of desired features for the modern antihistamines according to the international guidelines. I may say it has mostly 90 to 95% of fulfilling criteria to the ideal antihistamine. So structurally we can say that there is a hydrophilic moiety, which is a hydrophilic carboxylic substitute, which makes it low penetration into CNS and thus causes low sedation. And obviously it has been approved by DCGI for the symptomatic relief of allergic conjunctivitis, seasonal or perennial. It has also been approved by European Academy of Allergy and Clinical Immunology, so it is accepted worldwide, and it has been approved in 2010, and it had been introduced in clinical practice in 28 countries, and we are also in one of them, so it is globally accepted. Now, in coming to pharmacodynamics of the belastin, as we have said, it is H1 receptor antagonist and has an anti-inflammatory effect and highly selective. Now, basically, this point is very important that belastin has threefold greater affinity than cetirizine and fivefold greater affinity than that of fexofenadine. And I was shocked after reading this because belastin is much better, have much better affinity to H1 receptors than cetirizine and fexofenadine. So the belastin shows a long drug target residence time. That is, it has more half-life and more attachment to the H1 receptors, and this result in prolonged H1 receptor antagonism, which results in increased concentration and increased time to reach to the maximum power, that is maximum concentration, that is 1 hour to 1.5. So though the action starts within half an hour, and it can sustain up to 26 hours, as half life is 14.5 hours. So from 30 minutes to 26 hours, the action is there. So it's quite a good time. Uh, the action persists. So single dose is the ideal dose to give belastin, and it is convenient also. For metabolism and excretion point of view, it has no effect on no interaction with the peak cytochrome P450. So it is minimal metabolism in liver, and excretion, urine. You can see it is excreted only 28% in the urine and rest of is in feces. So in this, the if the patient is having liver dysfunction or renal dysfunction, there is no need to adjust any dose of belastin, which is a safe drug, and thus it has a superior parameters. Now, coming on the dosage of belastin, now belastin have been studied in children's at the dose of 10 mg per once daily, and it has been licensed for symptomatic relief of urticaria in children 6 or 6 to 11 years. Though the guidelines have also showed that above 12 years it is totally safe, and from 12 years it can be given to 20 mg per dose once a daily. But in children's, the it has been in area guidelines also it established that it can be given to from 6 years to 12 years or more. The 6 years to 11 years, the criteria is that the body weight should be at least 20 kg. This is the approved one, which is the guideline one. But and it should be 10 mg, and that comes to be 4 ml in the oral solution, OD. And it should be given before meals or after 3 hours of meals. That is, it should be given empty stomach. Now, in clinical practice, many have asked that whether we should give below 6 years also or not. So there are some randomized control studies which suggest that uh, below uh, from 2 years to 6 years also it is safe, though it is not included into the guidelines. But in clinical practice and as an experience, and as some studies have also shown that it can be used from 2 to 6 at same dose 10 mg. Now, basic indication is treatment, symptomatic treatment of allergic rhinoconjunctivitis, can be seasonal or perennial, and urticaria. And belastin is indicated in adults and adolescents 12 years over. So, my opinion, like from 2 years to adulthood. So, advantage of belastin is no dose adjustment in renal and hepatic impairment, no sedation, cognitive impairment, no anticholinergic effect, but need studies for the use in pregnant women. So we need to be cautious for that. In this study, we have shown that belastin at the top have the lowest non sedating effect. This is totally non-sedating, and rest others have a sedation effect as we go down to the first generation. So it is also called non-brain penetrating antihistamine. This is a word given to this drug. So a study was also conducted to see that how long can we give. So this study was done from 2 years to 11 years, and it was multi-centered phase 3, and it was given only in allergic rhinoconjunctivitis. 10 mg was given with versus placebo, and it has shown that from day 0 to week 12 there was no change or effect uh, in the side effect or at any adverse effect in the children. So we can safely say that the patient can be given to 4 weeks of course can be given very safely to the child or any patient. Now, belastin joins cetirizine, levocetirizine, loratadine as second generation antihistaminics and has been approved for use of pediatric patients for which long term safety data are available. Now, what is the course on belastin versus cetirizine and fexofenadine? As we have already said that the belastin have a higher affinity than cetirizine and fexofenadine. So in Vienna challenge, belastin has rafenadine was similar on day one, but less effective on day two, indicating a shorter duration of action. So in overall, belastin overcome or became the first candidate for above cetirizine and fexofenadine to be given to the child for allergic rhinitis or uh, uh, urticaria patients. Now, what is the take-home message? The belastin is potent. It is highly selective H1 antihistamine, has rapid action, no longer duration of action, less sedation, no renal or hepatic impairment. It tops the list of anti-allergics in antihistamines in second generation. It can be safely used in young patients also. Just we have to take care if the patient have a very is this case of long QT interval or congenital QT prolongation, then we have to be precautious. And in pregnant women, there are still studies are not so conclusive. So there we have to be precautious. But belastin meets the current European Academy of Allergy and Clinical Immunology and allergic rhinitis and its impact on area asthma, that is area guidelines for medications used in treatment for allergic rhinitis. So I thank by giving my presentation on belastin. So I hand over to Dr. Jog.
Yes,
so he
yes,
can
Divyank. Thank you for an
proceed further.
excellent elaboration of the new molecule.
Hello?
Yes, yes.
Yeah, I stopped.
No problem. This
Yeah,
bilastine.
yes, sir. I stopped the question.
Now, have you finished your presentation? Yeah. Okay.
Yes, sir. Yes, sir.
Great, thank you. So we will come back when there is a question answer discussion. So as I can get from your discussion, this new molecule gets almost 10 on 10 points from all the various studies that you mentioned and the guidelines. And just as a new film release is either super hit or hit or whatever it is, this molecule has already become a super hit, and I hope it continues to achieve the first position in the antihistamines, particularly the second generation non-sedating antihistamines. These days, as everyone knows, even if a person sneezes in front, people run away. This is because of the COVID situation. So it is necessary that everyone knows everything about the antihistamines. Okay. Anyway, now we have Dr. Anuj Rastogi, who will share his experiences related to Bilastin for over whatever years of experience he has related to the use of this molecule. So over to you, Anuj.
Thank you, sir. Thank you. And when this drug was launched to me last year, I was little skeptical about Blastin, whether I should use it or whether I should not use it. But I keep reading about this drug, and there were certain there are few patients those who are not ready to take Allegra or Faxi. There I have used this, and I found it is very effective and it is very easy to administer. So whenever I select any drug and I prescribe any drug, I try to keep doses to the minimum amount or minimum time it should be given. So this was the first thing which has attracted me a lot, because this drug has to be given once a day, and that there was no problem with the taste part of the drug, because as a pediatrician we have to look for it. Sometimes we write like we advise ciproxime syrup, and I know practically everybody will be coming and complaining of the vomiting or child is not accepting that drug. So as a pediatrician we have to be little cautious, because we want drug to be effective also and workful also. And there was no issue so far. I'm using it for last more than 1 year. There is no taste issue, and nobody is coming back to me for Blastin as such, whether child is taking this or child is not taking this. Second, the effect part. Gradually, I started building up my confidence on Blastin, as acute urticaria is quite common in general population, and children quite often, one or two children, they come once a week with severe urticaria. Earlier on, our policy was to use hydroxyzine and fexofenadine together, or sometime we had ranitidine or famotidine if child is not responding. But after reading this drug, I've started using this. Earlier on, I was using fexofenadine, and there I was escalating the dose of the drug. Like if child is not responding, even I was prescribing 10 ml twice daily or thrice daily. But that thing has become easier now. I prescribe them Belastin, and if child is not responding or child is not having relief, because it takes 1 to 2 hours to produce its effect. But if it is not doing complete histamine block, then I ask them to give one more spoon, or sometime I ask them to give 4 times of the dose. In literature, it was suggested you can go up to 11 times of this dose and safely, and there is no drug interaction and no side effect with this drug. And practically, I have not noticed any side effect with the drug. I'm very cautious in prescribing drug, and I try to prescribe minimum number of drugs rather than using maximum number of drugs, because as you escalating the number of drugs, then you will have more side effects. With Blastin, Satrogen and Fexofenadine, there are many drugs which metabolize through cytochrome pathway. But for Blastin, it is P-glycoprotein that is if that is used in that is used in um this P glycoprotein that is used in uh, that was used for the metabolism of this drug. So there are quite a few drugs, very few drugs, those who are using P glycoprotein like digoxin, anti-tubercular drug, corticosteroid, where this is important. So those drugs which are inhibiting P glycoprotein or those who are inducting P glycoprotein, there it affects the metabolism of the concomitant drug. So, but as such, there are, right now there is no study of blastin along with anti-tubercular drug or with digoxin or corticosteroid. But as such, there is no side effect. There is no need to modify the drug doses. Like with cetirizine, there is a side effect with concomitant use of ketoconazole or erythromycin, but here it is not required. As Dr. Divyang already mentioned this, it does not prolong QT interval. But there is a word of cautious, as literature suggests, you should use with cautious in hypokalemia, in hypermagnesemia or dyslipidemia. There you should, otherwise also you should use every drug with cautious because there is some potential of cardiac arrhythmia. And these days, like we are getting many patients of celiac disease. Celiac disease is very common in north part of India, and there this is Blastin is a gluten-free drug. You can safely use this in celiac disease also. And this is very fast acting this is a good drug for acute rhinoconjunctivitis as well as for urticaria. Even chronic spontaneous urticaria, this is supposed to be good drug. And you can go, rather than adding one more drug, you can go up to the 4 time of this drug. So I have used in chronic urticaria in quite a few patients along with emollient and other preventive measures. This works like anything. Now I do not require to use cocktail of using hydroxygen with some anti-allergic along with ranitidine or sometime with the steroid. So by and large, this is a very effective drug, very safe drug, and I am very happy with the uses of this drug. And that if for the bigger children where I am using the tablet part, the tablet is very small, and since it has to be taken for a longer period sometime, like for if you want to use this for perennial rhinitis, then you may go up to 12 months, although there is no study in children for up to 12 months, but in adult it is safely it is well tolerated for 12 months. And drug interactions also become very important when you have to use it for a prolonged period. But those children, those who have frequent allergies or those who are having allergies, rather than using this drug as on SOS basis, it will be more effective if you continue this for a few weeks. So I can sum up my experience by this, and I welcome you all to ask question about the molecule.
Okay. So thank you, Anuj, for giving this important information. And we will have some questions from our audience. Now, already the questions have started pouring up, and I will take up some relevant questions. So one of them is, there is a lot of discussion about the combinations of antihistamines along with montelukast. You get levocetirizine with montelukast, fexofenadine with montelukast. Even we see some preparations where there is belastin with montelukast. So how you look at this combination when it comes to management of either allergic rhinitis or urticaria? So what are your views on this, Anuj?
Sir, as a matter of fact, I am not. Montelukast is not my favorite. If I feel a child is having asthma or allergic rhinitis, I will go for inhalers or nasal sprays rather than beating around the bush or using Montelukast, because I am very much influenced by Dr. CLRA, who is my teacher and mentor, who taught me bronchoscopy, who taught me respiratory medicine, and he always says this is a leukotriene inhibitor, and leukotriene is the only part. It's not the only part in the asthma or in allergic disorder. So it's one of them. So you are only blocking leukotriene, but still, I feel this is a good drug. Montelukast is a effective drug in exercise-induced asthma. And if I strongly feel child is responding to nebulizer or child is responding to beta agonist, so then I ask them to use inhalers with huff puff kit or nasal sprays rather than using nebulizer haphazardly off and on. So I am not quite fascinated by this combination. And even levocetirizine or cetirizine, they causes dryness. they make secretions viscid. What else other cough syrups are used? They are used more for their side effect rather than effect, because in viral infections, in viral LRTI, there is no role of any anti-allergic, because that is basically a viral infection, viral flame. There they are using CPM or other drug just to cause dryness of the secretion, like all Triamnic, Sinarest or Maxtra, all type of drug, they reduces the secretion by drying the secretion. It is in fact, it's not reducing secretion, they are drying the secretion. So even with levocetirizine or cetirizine, if you are using this combination, they are also drying the, when you are using it for prolonged period, they causes dryness of the secretion. So I don't prefer this combination. And if at all I have to use, I will use Montelukast separately.
Yeah, I think that's very good that you gave a clear cut message. So the traditional romance of these combinations is not acceptable to you. That's good. In addition, there is one more factor, and that is the antihistamines are usually acidic, and Montelukast is alkaline. So when they come together, the combination is not stable, particularly in a syrup form. Though in a tablet form, some people they do put a biolayer, and that's a different story. But some or the other, this combination is not a preferred one. Now, I always say that there are two types of allergic rhinitis: the seasonal allergic rhinitis SAR, and perennial allergic rhinitis, that is PAR. Okay, so these two varieties of allergic rhinitis, do you have any particular preference of any antihistamines in your practice, Anuj? Do you have any particular preference?
Sir, first of all, I try to make a diagnosis. If I feel this is allergic rhinitis, I am going to go for this momentous nasal spray, because it has to be administered one time in a day, along with short-term uses of desloratadine or some anti-allergic. But since this Blastin has been introduced, and now I am building up my confidence on the molecule, I am using this only. And I fear, because my chemist, he keeps saying, keeps showing me loratadine and cetirizine, doxab, this stock is lying. But I am in so much love with the blast, and I'm not using other drug these days, because there is no side effect and it is very easy to administer these drugs. Earlier on, I was using loratadine and sometimes cetirizine as well, or quite often fexofenadine. But with fexofenadine, there is no clear cut drug doses guidelines. First and second, it has to be administered 2 times or 3 times. I always prefer drugs which has to be given 1 time. Otherwise, sometime when you write medicine which should be given 3 times a day or 4 times a day, and then you write 4 5 medicine, it is very difficult for parents to administer those drugs, and sometimes they end up giving wrong medicine, and they are missing the main drug, because like you want to give antibiotic with cough syrup and other things, then they will not give antibiotic, they will end up giving cough syrups only. So I have to create a balance to give good result, and I already explained them, it is going to take some time, you keep patience rather than jumping on the drug and trying and expecting miracle on day one. So we do not have any magic wand. They have to have patience, so that their child can be better with minimum drug and minimum cost.
Okay, very good. Now, Divyank, we would like to know from you about the administration details, how often it should be given, and whether it should be given on a full stomach or empty stomach, and how long to give this molecule when a child comes from mild intermittent type of allergic rhinitis. So, can you just elaborate in brief?
So first of all, as I have already said that the belastin has a long half life, and the action is long. So it is better to give once a day. So the dosage regime is for only OD. But as the sir have already said that if the symptoms persist, then we can increase the dose. We can increase the dose to BD or TDS, or double the dose or triple the dose, or give once. These two things can be done, but it is only for those who are not responding to belastin. In general, most of the cases of urticaria and rhinitis, OD dose is enough, and below 12 years we should give 10 mg OD, and above 12 years we should give 20 mg OD. And this is the basic regime, and as per the situation, we can go on double the or triple the dose. Just now, just before this, if in fact, just before I just started the webinar, there was a patient of allergic rhinitis and asthma and urticaria, and I just started my webinar, and Dr. Jog was introducing, and I just showed her that she listen the talk and get some knowledge about these things. Now, since I have started Bilastin, now she's always fine and totally fine, and she doesn't. We have reduced the nasal steroids also, and the skin problems have also reduced. So that was a very live example at that time, and so she was happy, and she came first time to me with no complaints and just for and follow up. So that is a property of Bilastin. Now, administration part, in Bilastin, we should go for empty stomach. Uh, as I have already said that the Bilastin should be given empty stomach, or just if the patient has taken a meal, just wait for 2 or 3 hours and then give Bilastin. So it's more effective. And for long, how long duration? If the patient is of mild category, there are two types: mild or severe, or persistent or intermittent. In intermittent or mild, you can give for 2 weeks to 3 weeks, for 1 week to 2 weeks. But if the patient is having severe or persistent category, then you should continue for at least 12 weeks or 3 months. Then you should see the response, and then you should start tapering off, or you should stop and see the response, rather than directly going on steroids. I should say, have patience with Bilastin, that don't directly shift to steroids. If the patient is not responding to Bilastin by increasing the dose, then obviously you should consider steroids, or there is any asthma related problems, then obviously you should go with ICS.
Yeah, thank you. Because I know quite a few colleagues, they have this formula of ABC, antihistamines, bronchodilators, corticosteroids. Koi bhi aane do, laga dunga. So I think that particular habit should be avoided. And of course, nebulization is required very rarely these days. We all go for inhalers, as Anuj also mentioned earlier. So as I can see from you, Divyank, दिन में एक बार खाली पेट ले ले, फटाफट असर, दिन भर असर, नींद पर नहीं असर. Am I right? So this is how you can explain to the parents also. Now, Anuj, a question for
Yes,
you,
sir.
and
Totally.
I expect quick answer from you as to what is the safety profile about the duration. That means a child has come to you for mild intermittent allergic rhinitis or some acute urticaria. So how long do we give it? 3 days, 5 days, 7, 10 days, 2 weeks, or 4 weeks, 6 weeks? So
For,
what is your experience
for
and how we look
I usually give for 2 weeks because it takes its optimum effect start coming after 3 days because it takes 72 hours to get complete histamine block.
at?
So
Okay.
I try to maintain this for at least for 2 weeks, and I explain to the parents it may, when you will stop the drug, it may reappear also, but don't worry, you again start this because generally it is urticaria in children is viral induced or sometime rarely with drugs also and sometime because of mycoplasma. So as such, 2 weeks minimum I continue, and rarely I may require because there are subset of patients those who land up into the chronic urticaria, so they passes that through this stage also. Because once it is more than 6 week duration, then it is known as chronic urticaria, so you have to continue for long period. As such, for acute urticaria, 2 weeks is good enough. And studies are there which has shown in even in children from 2 to 12 years, although it is not recommended at the age of 2 year till now, but the studies are there from 2 to 12 year. It can safely be used for 2 to 3 months. It is very
Okay.
very well tolerated drug for children. Yeah.
Okay. Okay. And we have always been saying that it's a non-sedating antihistamine. So, in which particular cases you feel that this particular advantage of Bilastin is useful in pediatric practice?
As
Get me
such,
to know.
where
Yeah.
the when children are giving exams and they few of them they are driving also or they are cycling also, they should not be feel sedated. Although
Right.
children meet sedation very easily because they are not complaining, but as a matter of fact, they should not be over. We should not give overdoses to them. So practically for all the allergies, I am using this, and I am finding it very useful. And especially if a child is having exam, so I don't want them to be sedated through some medicine, so I give it to them. And there is a
Yeah.
biscuit study. Biscuit, there is head-to-head comparison between the hydroxyzine and blastin. They have monitored the vigilance and the tracking of the subject. It is done in the adult because this was launched by the FES Pharma, and they have done this viscous studies. And for 1 week, they have given hydroxygen also, and 1 week blastin also. So there was no effect on the performance of the pilot with blastin. So they have produced a cabin type of atmosphere on the ground, and they have used hydroxygen and blastin. So it was found superior to the hydroxygen. So it can be given for a when you are driving, and children luckily they don't consume alcohol, so there is no study. For adult, it can be given along with alcohol also. And there is one very good aspect of this drug: it does not causes photoreaction. It does not make photochemicals into the skin because it absorption of ultraviolet rays is out of that range where the photochemicals are made, and they causes photodermatitis. So this is again very good drug that does not cause photodermatitis also, because when you are using anything for prolonged period for weeks, then you should be having enough knowledge about the molecule. It is one dose or two dose that does not matter, but when you are using for weeks, then it is important. Like for chronic urticaria, especially in children, especially in young girls, thyrotoxicosis is a very important DD. Up to 5% of the chronic urticaria, they are having thyroid antibodies and hyperthyroidism. So there it become very important to select the drug, anti-allergic drug, and there you have to add antithyroid also.
Okay, very good. Now, most of the questions of the audience have been answered. I would like to ask a few last lines from each of you about the avoidance of the allergens, because no discussion on allergy can be complete without having your inputs on this. I already touched upon this particular subject little bit in my talk, but then Divyank, in brief, let us know what is your opinion about the dogs and the cats and the cockroaches in the house, in particularly about the indoor allergens. Yeah. So can you just share that? Yeah.
Yeah, if it is a perennial allergy, then we have to think of the indoor allergens. And in indoor allergens, mostly it comes with dust mite, cockroaches, pets. For dust mite, it is just the cleaning, washing, and keeping the area clean by mopping the area properly, not using the jhadu, like it should produce aerosol. It should be wiped out, and the bed should be cleaned, and the bed can be showed to sunlight so that dust mite should can be removed. And for cockroaches, it's like if cockroaches also, it's like cockroach is the second most common allergens in the house, which causes allergies. And if you found one cockroach in your house, then you may be having a whole lot of cockroach colonies in your pipes. So if you see one cockroach, then it's time to get pesticide treatment. And if there are a lot of cockroaches, then please uh, don't stay at your home for few days and then get it cleaned. There is one more thing, that cockroaches have allergens, and if you spat the cockroach with the chappals or something else, then it's just burst. And because of bursting, the allergens get aerosolized, and that causes more problem. So it by killing the cockroaches is also a style of avoidance. So just move them, or just catch them, or move them out of the house. And for pets, I can say that the exposure of pets to early childhood is very important for them to prevent the allergies. But if anyone having a pet allergies like in dogs, uh, it is better to remove the dog from the home or distance them, and clean the home with all the furs and all. And but one dog, if there is allergy with one dog, it doesn't mean that the patient will have allergies to all the dogs. But in cats, we can there is a study that if a patient is allergic to one cat, then he will be allergic to all the cats in the world. So cats are more dangerous, and maybe our mythology was way above that. कि काट और बिल्ली रास्ता काट देती है and all, something like that. So stay safe with these things. And obviously if there is a perennial allergies, then for prevention, there is a hygiene hypothesis. Then more you keep the child clean, more it is the chances is to get the baby allergic. So try to be more lenient with all the natural things in gardens. Mild dust, mild let him play anywhere, and just him enjoy his childhood, and just don't bombard him with the sanitizers, not for the COVID times.
Yeah, I can understand.
Thank you.
Though this hygiene hypothesis of late has come into a bit of controversy, the point is well taken. And I always say that all the pets should be out of the bedroom except the husband. I hope you agree with me. And then Anuj, you have the additional comments from your side about allergen avoidance. Anyone from your side?
You see, there are two, three things which is not adopted in North because here mm, we do dry mopping of the floor rather than wet mopping. Wet mopping sometime, but dry mopping is must. Like सुबह झाड़ू लगाना सबके घरों में बहुत जरूर एक cultural belief है. So there, where you have allergy problem, you should not have any carpet. You should clean your curtains with vacuum cleaning, and you should clean your AC filters every week. It's not a difficult. You have to develop this culture also, and like you should remove your shoes and slippers before you are entering into your house, and you should always dry your clothes wet after washing clothes inside the house where sunlight is coming. I mean indoor. Inside the house means कमरे के अंदर ही आप कपड़े सुखाइए so that dust should not invade over the clothes. And you should take bath in the evening, especially in the evening, because all the dust is sticking over your head, over your face. That will be clean after taking bath. And you should have pre-washed clothes. I always ask them to have new clothes at that bad time, whether you wear new clothes in the morning or not. It is not very important for allergy, but for the night, because you're the most of the time of 24 hours with very very busy people also that passes in their house. So it is easier to control the indoor dust or indoor allergens rather than outdoor allergens. So you are going to be in your house between 12 to 18 hours, so it become very important. You should, and in during the pollen season you should keep your window closed. You should not keep your window open during the pollen season. So these are the few tricks which one should always practice along with anti-allergic treatment, because here people they come for drug only. They don't follow the advice. They ask जाते जाते पूछेंगे क्या खाना है, जैसे खाने से ही सब कुछ हो रहा है, and they will not follow any other advice. और खाने में भी मुझे नहीं लगता वो कुछ करते होंगे, बस पूछते तो जरूर.
Right. Yeah, I agree with you. But at the same time, all these tips that Divyank and yourself gave, they are extremely important, because that's an important part of the management of allergic rhinitis. And I always tell the young adolescents, when they offer a flower of rose to their beloved ones, please be careful, because instead of smiling, she may start sneezing after smelling the rose because of allergy to the pollens. So be careful. Anyway, my dear friends, many times I feel that a case like allergic rhinitis or urticaria should be kept in the MBBS or the MD exam, because nobody gives importance to this particular topic, and so much of information to be discussed. And you must also inform the parents that this is a condition which is controllable but not curable. Just as asthma is controllable, it's not curable, and one has to be very, very clear about it. So my dear friends, we have discussed about allergic rhinitis and comorbids. We have also taken the information of bilastine as a new kid on the block, and we have seen that it's a molecule which has a rapid onset of action, a prolonged duration of action. It can be safely given in those who have comorbids like hepatic renal involvement or cardiac problems, and it does not produce sedation. It's a safe molecule, and it has many, many advantages. And as I said, it gets 10 out of 10 marks. It has been recommended by the European guidelines as well as the area guidelines, and I am sure that more and more research would bring this particular molecule into limelight in future. So I thank Dr. Anuj and Dr. Divyang for this lively discussion, and also thank our
Thank you.
friends from Ghaziabad and around for listening to this particular program and asking your questions. Thank you very much. Thank you.
Thank you, sir. Good night.
Thank you.